Look down at your hands. I mean, as plastic surgeons, and especially for those of you rigorously preparing for your FRCS board exams, we usually view the hand as, well, pure engineering.
Right. It's a highly precise mechanical system.
Exactly. It's a system of pulleys, levers, and stable structural supports doing exactly what we dictate.
You want to execute a complex surgical maneuver. The extrinsic and intrinsic muscles fire. The joints hinge. And the job is done.
Yeah, we are basically trained to view joint pain or hand deformities as simple mechanical failures. A ruptured tendon, a fractured phalanx.
Purely local wear and tear on the machine.
Right. But stepping into the clinical reality of inflammatory arthritis completely shatters that localized mechanical view.
It really does. It changes everything.
Because we are looking at a diagnostic landscape where the hands function as these highly sensitive dashboards, they're displaying the internal systemic battles happening throughout your entire body.
Which is a huge mental shift.
It is. And that is our mission for this deep dive. We're unpacking 3 incredibly distinct inflammatory hand conditions today.
Psoriatic arthropathy, systemic lupus erythematosus, and gout.
Yeah, we're going straight into the clinical mechanics to understand how these systemic diseases physically reshape the hand, and of course the specific medical and surgical strategies you need to know to manage them.
So to establish a baseline for just how aggressively systemic inflammation can alter local anatomy, we really should start with psoriatic arthropathy.
Because it's characterized by the actual physical destruction and reshaping of the bone itself.
Exactly. Laying out the foundational basics here, this is an inflammatory arthritis found in patients with psoriasis. But it has a very specific presentation.
Right.
It is usually a seronegative oligoarthritis.
Okay, let's unpack this for the listener. Seronegative means that if we run blood work on these patients, they are rheumatoid factor negative.
Correct.
And oligoarthritis refers to the pattern of joint involvement, meaning the arthritis typically targets just a small number of joints, usually 2 to 4, rather than being all widespread polyarthritis.
That defines the parameters perfectly. And demographically, this condition typically develops in patients between the ages of 35 and 55.
Okay.
And interestingly, there is absolutely no sex predilection. It affects males and females equally.
That's good to know for the exams.
Yeah, but a crucial statistical reality to remember for the boards is that having the cutaneous manifestations like the psoriasis on your skin does not guarantee you will get this bone and joint condition.
Wait, really? What's the percentage?
Only about 10% of patients with the skin disease actually develop this inflammatory arthritis.
Oh, wow, 10%. Well, looking through the clinical notes, the medical terminology used to describe what happens to the hands in that specific subset of patients is unbelievably vivid.
It really is.
The literature uses terms like arthritis mutilans and the opera glass hand or la main à lorgnette.
Right, the French term.
Yeah. So is the bone structure literally collapsing in on itself like a collapsible pirate's telescope?
It's exactly like that. There is a complete collapse of structural integrity.
That sounds horrific.
It's severe. Now, arthritis mutilans is the most extreme form of this condition, though thankfully it affects less than 5% of these patients.
That's a relief.
But it results from a process called osteolysis. The bone itself is actively dissolving.
Melting away.
Exactly. The calcium matrix is being reabsorbed, leaving a void where rigid structure used to be.
So if the rigid structural support of the bone is literally dissolving away, the surrounding soft tissues, like the skin and the tendons, they don't just magically shrink to match the new bone length.
No, they remain exactly as they were.
Right.
So the physical telescoping of the remaining bone fragments collapsing into one another leaves redundant, loose folds of skin surrounding a drastically shortened, mechanically useless finger.
Wow.
That is the physical mechanism behind the classic opera glass hand.
That paints an alarming picture of what severe systemic inflammation can do. But as you noted, arthritis mutilans is the rarest form.
Right, less than 5%.
Moving to the more common clinical signs we might see in an examination, the literature points to involvement of the distal interphalangeal joints.
The DIPJs, yeah.
Closest to the fingertips, right? That happens in about 10% of cases. But even more common are acute attacks affecting the entire finger.
Yes, occurring in 35% of these patients, you are referring to dactylitis.
Commonly known as a sausage finger.
Exactly. Clinically, instead of inflammation being isolated to a single joint capsule, the systemic attack triggers severe simultaneous inflammation along the entire digit.
So it completely obliterates the normal contours of the finger.
It does. It just swells up entirely.
Now, if we were to put these deformed, inflamed hands under an X-ray, the radiological features are just as distinct as the clinical presentation, right?
Definitely. You see asymmetric joint surface erosions.
And acrosteolysis.
Right, which is the physical erosion of the tuft of the distal phalanx. The very tip of the fingertip bone simply wears away.
But the most famous radiological hallmark you absolutely have to know for the boards is the pencil and cup deformity.
Oh, the physical physics of that deformity are fascinating.
Break it down for us.
Okay, imagine the joint between two finger bones. Through this destructive remodeling, the articular surface of the distal phalanx is aggressively eroded into a concave shape.
Essentially hollowed out like a cup.
Right. Meanwhile, the bone right behind it, the middle phalanx, is eroded down into a sharp, convex point.
Like a sharpened pencil resting inside a hollow cup.
Exactly. The extreme bone resorption is completely reshaping the joint's articulation. It is a hallmark sign of the disease process.
So if this aggressive bone dissolution is happening below the surface in only 10% of psoriasis patients, we need a reliable way to predict who is at risk.
We do. And the diagnostic tell is sitting right at the ends of their fingers.
The nails.
Yes, diagnosis here is based primarily on clinical and radiological findings, but nail changes are a massive indicator. 80% of patients who have the arthropathy exhibit characteristic nail changes.
80%.
Yeah, compare that 80% to only 20% of patients who have uncomplicated psoriasis without the arthritis. That is a massive diagnostic leap.
Let's break down exactly what we are looking for on the nails. There are 4 key clinical signs, right?
Right.
First, uniform nail pitting. Those are tiny little dents across the rigid surface of the nail plate.
Correct. Second is leukonychia, which presents as white discoloration or opaque spots on the nails.
Indicating abnormal keratinization.
Exactly.
Third is on onycholysis. That is the painless separation of the nail plate from the underlying nail bed.
The nail is physically lifting off the finger.
And fourth is subungual hyperkeratosis.
Right. With subungual hyperkeratosis, you will see a buildup of thick, chalky, excessive tissue stuffing itself underneath that lifted nail.
Disgusting, but very clear. So if you are examining a psoriasis patient and observe these 4 signs, their risk profile for the underlying destructive arthritis is exponentially higher.
Without a doubt.
For those high-risk patients, our intervention strategy needs to be aggressive. The mainstay of treatment is absolutely medical.
We rely on disease-modifying anti-rheumatic drugs, DMARDs, along with NSAIDs, advanced biologic agents, and intra-articular steroid injections.
We have to halt the systemic inflammation before that irreversible bone dissolution occurs.
Because once the bone is gone, surgical intervention is strictly indicated for salvage.
There's no going back.
No. We are looking at arthrodesis, fusing the joint in place to provide some baseline mechanical stability.
Or arthroplasty, which is total joint replacement.
Yeah, and in severe cases of arthritis medialins, surgeons are sometimes forced to use bone grafts just to physically lengthen the digits back out to a functional size.
Unbelievable. So
Yeah.
psoriatic arthritis is a clinical story of the bone itself physically melting away. If we connect this to the bigger picture, what happens if the systemic immune system leaves the bone completely alone and instead attacks the tension cables holding the entire structure together?
That brings us to our second condition, systemic lupus erythematosus, SLE.
SLE. This is a complex systemic autoimmune disorder.
It is. And demographically, it paints a completely different picture than what we just discussed. The mean age of onset is much younger,
Like teenagers.
typically between 15 and 25 years of age. And the sex predilection is severe. It has a female-to-male ratio of 9-to-1.
A 9-to-1 female-to-male skew is massive.
Very massive. In terms of sheer prevalence, it has an annual UK incidence of about 5 per 100,000 population.
And there's another systemic indicator you will frequently observe in these patients, right?
Yes, Raynaud's phenomenon, where the blood vessels in the hands and feet violently overreact to cold or stress, causing severe vasospasm.
Here's where it gets really interesting for me. If you look at the hands of someone with severe SLE, they present with deformities that look almost identical to rheumatoid arthritis.
They do.
The fingers can be severely angled, swollen, and completely out of alignment. But the data clearly states that in contrast to RA, or psoriatic arthritis, there is absolutely no erosive arthritis in SLE.
None at all. The bones are perfectly fine.
The illusion of erosion.
Exactly. The deformity arises almost entirely due to ligamentous laxity. The immune system is targeting the connective tissue.
Oh, wow.
It attacks the very ligaments that are supposed to hold the joints tightly in their proper anatomical alignment, causing them to become incredibly loose, stretched out, and slack.
So the structural scaffolding of the hand is completely intact, but the ropes holding it together have lost all their tension.
Beautiful way to put it. The joints simply slip out of alignment.
Which explains a really critical, counterintuitive clinical feature of SLE in the hand. The pain experienced by the patient is typically vastly disproportionate to the actual degree of visible swelling.
Yeah.
It hurts immensely, even if the hand doesn't look massively inflamed, because the joints are constantly mechanically unstable. They're sliding around with every single movement.
Right. The mechanical friction and instability drive the pain profile.
Okay, so pushback here. If the bones are fine and the soft tissues are just loose, why wouldn't surgeons just go in, tighten the ligaments, and reconstruct the soft tissue to pull the joints back into place?
It's a great question, but you have to remember the underlying systemic autoimmune attack on the connective tissue is ongoing.
Ah.
So any soft tissue reconstruction we attempt is doomed to fail. The new ligaments would just stretch out and loosen up all over again.
So the recurrent failure of soft tissue procedures in SLE is just a known clinical reality.
Yes. Because of that relentless soft tissue laxity, any reconstructions are frustratingly short-lived. The underlying disease process dictates the surgical protocol here.
So what's the solution?
When surgical intervention becomes absolutely necessary, surgeons must rely on arthrodesis. You have to fuse the bones together to create permanent, rigid stability.
And we avoid arthroplasty joint replacement for the exact same reason, right?
Precisely. An artificial joint still relies on the surrounding ligaments and tendons to function.
And if the soft tissue envelope is fundamentally unreliable, a joint replacement will simply dislocate.
Right. Arthrodesis gives the patient a functional, albeit stiff hand. But ideally, we manage this medically long before surgery is ever needed.
What's the medical frontline defense?
We use NSAIDs, antimalarials, immunosuppressants, biologic agents, and corticosteroids to modulate that autoimmune response.
Wait, really? Antimalarials?
Sure.
Like the drugs you take before traveling to a tropical climate?
Yeah, exactly.
Why are we using antiparasitic drugs for an autoimmune joint issue?
It seems like a paradox, I know, but drugs like hydroxychloroquine have potent systemic immunomodulatory effects.
Oh, interesting.
They interfere with the communication signals of the immune system, effectively damping down the aggressive autoimmune attack on the connective tissues.
And I guess that avoids the severe side effects of long-term high-dose corticosteroids?
Exactly. It's a much safer long-term option.
Okay, we've looked at an autoimmune skin-related condition that dissolves bone and a connective tissue disorder that pulls joints out of place. Let's shift away from autoimmune diseases entirely.
Let's do it.
We are moving to a purely metabolic issue, where microscopic crystals cause absolute mechanical and inflammatory havoc. We are talking about gout.
Gout. It is an inflammatory arthritis characterized by self-limiting, excruciatingly painful acute attacks. And demographically, we see another stark shift here.
Right.
Males are affected 4 times more commonly than females.
The mechanism here is completely different from SLE or psoriatic arthritis. The body isn't randomly attacking its own healthy tissue.
No, it is reacting to a localized physical irritant.
The chemical spill.
Right. It is caused by the intra-articular and periarticular deposition, meaning inside the joint capsule, and in the surrounding tissues of monosodium urate crystals.
Oh, MSU.
MSU, yeah. And these crystals are explicitly needle-shaped.
Literally microscopic sharp needles forming and precipitating inside the joint fluid.
Exactly.
The body's immune system detects these sharp urate crystals, recognizes them as foreign mechanical irritants, and mounts a massive, fierce inflammatory response.
And that localized immune war is what causes the excruciating pain of an acute attack.
Right.
And while those acute attacks are self-limiting and eventually subside, recurrent attacks are highly destructive.
Cumulative damage.
Over time, they cause severe cumulative joint damage, mechanical joint instability, and even tendon ruptures as those needle-like crystals physically abrade and weaken the soft tissues with every movement.
This brings up a critical diagnostic fallacy we need to address for the boards. So what does this all mean for someone's diet? Most people assume gout is just about eating too much rich food and getting high uric acid.
It's a very common assumption.
If a patient comes in with an incredibly painful, red, swollen joint, but their blood tests show completely normal uric acid levels, Can we rule out gout?
What's fascinating here is no, you
Yeah.
cannot rule it out. Yeah. While monosodium urate is derived from uric acid and hyperuricemia, high uric acid in the blood is the major risk factor for developing gout, the relationship is not perfectly linear.
Explain that.
Not everyone with high uric acid develops crystal deposition, and crucially, acute gout attacks can and frequently do occur with totally normal serum uric acid levels.
Because the uric acid is no longer in the blood.
Exactly. The systemic level drops as the uric acid precipitates out of the blood and into the joints to form the crystals.
That is a vital distinction. So we need to look at where this excess uric acid is coming from in the first place, regardless of the blood levels during an attack.
Right. We divide hyperuricemia into primary and secondary causes.
Okay.
Primary hyperuricemia is basically an internal hardware issue. It usually involves a decreased renal clearance of uric acid, meaning the kidneys simply aren't filtering it out of the blood effectively.
Or rare inborn errors of metabolism.
Yes, exactly.
And the secondary causes are external or acquired factors. These include specific medications, particularly diuretics like thiazides, which actually interfere with the kidney's ability to excrete uric acid.
Secondary causes also include myeloproliferative disorders.
Right, the bone marrow.
Yes, the bone marrow is overproducing blood cells at a massive rate. That rapid cell turnover means millions of cells are constantly breaking down, releasing their purine-rich DNA.
Which the body then metabolizes directly into uric acid.
Exactly. And the exact same mechanism applies to cytotoxic drugs used in chemotherapy.
You are deliberately destroying massive amounts of cells, creating a flood of purines that the body has to convert into uric acid.
Yes. And finally, we get to the classic lifestyle factors. High alcohol consumption, excessive dietary purine intake from certain meats and seafood, and diets that are high in fructose.
All of these overwhelm the metabolic pathways, spiking uric acid and triggering crystal deposition.
Now, if a patient grits their teeth through the acute attacks and years of untreated gout go unmanaged, it leads to a destructive condition known as chronic tophaceous gout.
Characterized by the formation of tophi.
Tophi, yes.
Tophi are physical subcutaneous nodules, hard lumps, sitting right under the skin, made entirely of massive, chalky deposits of uric acid crystals.
And they very commonly form in the hands.
At this chronic stage, most gout is aggressively managed in primary care or by rheumatologists with specific uric acid-lowering therapies, right?
Usually, yes. But surgical intervention is occasionally indicated. Surgeons may need to fuse or stabilize joints that have been physically destroyed by the crystal abrasion.
Or they may need to physically excise these symptomatic tophi.
Right. If they become so large that they interfere with hand function, or if they threaten the viability of the overlying skin by eroding right through it.
Before we wrap up this metabolic section, we have to quickly address the imposter condition, pseudogout.
Oh, pseudogout is a critical differential diagnosis. It presents very similarly to gout with acute, painful, swollen joints.
But the mechanism is different. It is caused by the deposition of calcium pyrophosphate crystals rather than monosodium urate.
Which fundamentally changes the long-term management strategy for the patient.
Right. With regular gout, we have specific systemic medications that target the underlying cause by lowering uric acid production or increasing its excretion.
But with pseudogout, there are currently no specific drugs that treat the underlying cause of calcium pyrophosphate deposition.
Which means long-term management is purely symptomatic. You are managing the inflammation, not curing the chemical imbalance.
Exactly.
Well, this has been an incredibly dense, necessary breakdown. Synthesizing all of this, it is truly staggering how vastly different systemic conditions. We started with the destructive bone telescoping, osteolysis, and pencil and cup joint dissolution of psoriatic arthritis. Then we examined the deceptive ligament laxity of systemic lupus erythematosus.
Where the bones are preserved, but the supporting soft tissues simply stretch and give way, making reconstruction nearly impossible.
And finally,
It reinforces the reality that you must look beyond the local anatomy. The hands are a highly visible dashboard for the body's overall systemic health.
everything is connected.
What happens in the immune system, the bone marrow, or the kidneys eventually manifests directly in the physical architecture of the fingers.
Which leaves us with a provocative final thought for you to mull over as you prepare for your exams. We've just seen how simple metabolic byproducts like uric acid or completely unseen autoimmune misdirection can radically alter and reshape the solid bone and dense connective tissue of our hands.
Yeah.
So you have to ask yourself, What other invisible systemic imbalances are silently reshaping our internal microscopic structures right now, long before they ever become severe enough to be visible to the naked eye?
That is the exact kind of systemic thinking required to master these clinical presentations.
Thank you for joining us on this deep dive. I hope it has completely shifted your perspective and that you bring this new interconnected understanding to the way you approach the human body in your practice and your exams.
Good luck with the prep.
Before you go, we encourage you to press follow on the show so you can listen to more deep dives just like this. And if you learned something valuable today that helps your board prep, please leave us a rating.
Absolutely. And if you want to take your clinical understanding to the absolute highest level, get a premium subscription to listen to the Journal Club and Clinical Cases episodes.
Be direct. Don't waste time. Check that out right now. And finally, leave a comment or a question below. We love seeing what parts of the pathological mechanism stood out to you.
We read all of them.
Until next time, keep questioning what you see on the surface.